and neuromuscular disorders. Must know, desirable no. 4-page exam answer, full 4-page, 2-page exam answer. Nice to know, MCQ level points only, not asked as long answer. LH learning topics only. Must know topics 4-page answers contains quadriplegia, Ashtantravadam, paraplegia, Arnavadam, poliomyelitis, motor neuron disease, MND, Parkinson's disease, Nadukuvadam, anhedonia, Parkinson's disease, Nadukuvadam, Panikambavadam, ataxia, incoordinated movements, peripheral neuropathy, Vadakarsanam, Duchenne's muscular dystrophy, Dasaivadam, oculomotor, trochlear and abducens nerve lesions, trigeminal neuralgia, facial paralysis, meninum and Bell's palsy, vestibulocochlear nerve lesions and deafness, benign paroxysmal positional vertigo, 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 benign paroxysmal positional vertigo. Desirable to know. Topics to be olfactory nerve lesions, anosmia and parosmia, olfactory smell nerve lesions, anosmia and parosmia, optic nerve lesion, visual pathway and optic atrophy, optic neuritis and retrobulbar neuritis. Nice to know topics MCQ only, myopathy and muscular dystrophy, classification, myopathy and muscular dystrophy classification, vestibular neuronitis, neuronitis. Must know topics, Ashtantravadam, quadriplegia, paralysis of all 4 limbs, both upper and both lower limbs with or without trunk involvement due to a lesion of the cervical spinal cord above C5, or bilateral corticospinal tract lesion above the cervical enlargement. Siddha correlation, Ashtantravadam, Valivada dosha vitiation, obstructing nerve conduction, nadi to all 4 limbs. Siddha correlation, Ashtantravadam, Valivada dosha vitiation, obstructing nerve conduction to all 4 limbs. Etiology, traumatic, cervical spine fracture, dislocation, cervical spine fracture or dislocation, RTA, diving injury, fall from height, fall from height, non-traumatic, cervical spondylitic myelopathy, cervical spondylotic, non-traumatic, cervical spondylotic myelopathy, transverse myelitis, cervical cord tumor, syringomyelia, cervical disc prolapse, Pott's spine, cervical TB, demyelinating disease, Pott's spine, cervical TB, cervical disc prolapse, cervical cord tumor, syringomyelia, cervical disc prolapse, Pott's spine, cervical TB, demyelinating disease, MSNMO, vascular anterior spinal artery syndrome, congenital Arnold-Chiari malformation with cervical cord compression, Arnold-Chiari malformation with cervical cord compression, congenital Arnold-Chiari malformation with cervical cord compression, Arnold-Chiari malformation with cervical cord compression, site of lesion, cervical spinal cord above C5 segment, bilateral corticospinal tract involvement, bilateral corticospinal tract involvement or brainstem, rare bilateral brainstem rare. If at all occurs, bilateral. Pneumonia causes of quadriplegia, trauma, trauma, RA, spondylosis, abscess, spot spine, unusual tumor, myelitis, anterior spinal artery, Chiari malformation, trauma, RA, spondylosis, abscess, spots, spine, unusual tumor, myelitis, anterior spinal artery, Chiari formation, trauma, rheumatic arthritis, spondylosis, abscess, spots, pain, unusual tumor, myelitis, anterior spinal artery, Chiari malformation. Clinical features: motor weakness of all four limbs, initially flaccid spinal shock, lateral spastic UMN, upper motor neuron lesion pattern, reflexes exaggerated, deep tendon reflexes, extensor plantar, Babinski positive after spinal shock results. Sensory loss below the level of lesion, sensory level on trunk, autonomic bladder and bowel incontinence, retention, loss of sweating below lesion, postural hypotension, respiratory diaphragmatic involvement if lesion at above C3 C5 phrenic nerve, respiratory failure. Others, priapism, autonomic dysreflexia in high lesions, hypothermia. Investigation purpose: MRI, cervical spine, gold standard, quad compression edema, tumor disc, MRI, cervical spine, gold standard, quad compression edema, tumor disc, X-ray, cervical spine, fracture, dislocation, alignment, CT spine, bony detail in trauma, CSF analysis, MS, infective muscular spondylosis, infective causes, NCS, EMG, differentiate from peripheral cause, blood, ESR, CRP, C-reactive protein, erythrocyte segmentation rate, VDRL and blood, infective autoimmune workup, treatment, management, emergency immobilization of cervical spine, hard collar, ABC management, avoid neck movement, ABC management, emergency, IV methyl prednisolone within 8 hours of acute traumatic heart injury, controversial but classically thought. Acute traumatic heart injury within 8 hours of controversial but classically thought. Treat underlying cause, antitubercular therapy for POTS, antibiotics for infective myelitis, immunosuppressants for MS, surgical decompression plus fixation for unstable fracture, cord compression, tumor excision, decompression, fixation, surgical decompression plus fixation for unstable fracture, cord compression, tumor excision, decompression, fixation for unstable fracture, cord compression, tumor excision, supportive bladder catheterization, bowel care, DVT, prophylaxis, pressure sore care, surgical decompression plus fixation for unstable fracture, bladder catheterization, bowel care, DVT, prophylaxis, surgical decompression, fixation for unstable fracture, cord expression, tumor excision, supportive bladder catheterization, bowel care, DVT, prophylaxis, pressure sore care, to Harley turning, respiratory support, ventilation if diaphragm involved, rehabilitation, physiotherapy, occupational rehabilitation, physiotherapy, occupational therapy, psychological support, physiotherapy, occupational therapy, psychological support, physiotherapy, occupational therapy, psychological support, Siddha rehabilitation, physiotherapy, occupational therapy, psychological support, Siddha aspect of treatment, Vali Vada pacifying, Kaya Karpam and Tokkanam, Vali Vada pacifying, Kaya Karpam and Tokkanam massage with medicated oils, Vada Kulandagai தைலம், வாத குழந்தகை தைலம், கற்பூராதி தைலம், வாத குழந்தகை தைலம், கற்பூராதி தைலம், வாத குழந்தகை தைலம், கற்பூராதி தைலம். இன்டர்னல் மெடிசின்ஸ், விஷமாஷானி வடகம், விஷமாஷானி வடகம், வாத குழந்தகை சூரணம், வாத குழந்தகை சூரணம், அமுக்குர சூரணம் ஃபார் நர்வ் நரிஷ்மெண்ட், விஷமாஷானி வடகம், வாத குழந்தகை சூரணம், அமுக்குர சூரணம் ஃபார் நர்வ் நரிஷ்மெண்ட், விஷமாஷானி வடகம், வாத குழந்தகை சூரணம், விஷமாஷானி வடகம், வாத குழந்தகை சூரணம், அமுக்குர சூரணம், விஷமாஷானி வடகம், வாத குழந்தகை சூரணம், Amukrachurna for nerve nourishment, Navarakili, Pindasveda, and Lavangam to improve circulation and muscle tone. Navarakili, Pindasveda, and Lavangam to improve circulation and muscle tone. Diet: Vata pacifying, warm, anxious, mildly spiced food. Avoid cold, dry, stale food. Diet: Vata pacifying, warm, anxious, mildly spiced food. Vata pacifying, warm, anxious, mildly spiced food. Avoid cold, dry, stale food. Avoid cold food, dry, stale food. Prognosis and prevention. Prognosis depends on cause and completeness of cord injury. Complete versus incomplete. Forward with complete transaction. Prevention: road safety, seat belt, helmet use, early treatment of spondylosis and TB spine. Avoiding neck manipulation in unstable spine. Road safety prevention: road safety, seat belt, helmet use, early treatment of spondylosis and TB spine. Avoiding neck manipulation in avoiding neck manipulation in unstable spine. Avoiding neck manipulation in unstable spine இருந்துச்சுன்னா example quadriplegia is equal to lesion above C5. If C5 to C8 T1 involves sparing of upper limb function, think paraplegia instead. ஓகேவா? C5 above இருந்துச்சுன்னா quadriplegia, C5 below இருந்துச்சுன்னா paraplegia. Diaphragm C345 keep the diaphragm alive. Lesion above this level needs ventilator support. Keep the diaphragm alive. Lesion above this level, above what level? Lesion above this level as C345 needs ventilator. Diaphragm, keep the diaphragm alive. These three: lesion above this level needs ventilator support. Lesion in C345 needs obviously ventilator support because it affects the diaphragm. Paraplegia Arunavadam, paralysis of both lower limbs due to lesion of the spinal cord below the cervical enlargement, usually thoracic or lumbar cord. Cauda bilateral parasagittal cerebral lesion. Siddha Kaurisha Arunavadam, aggravated worry dosha affecting the lower nodis causing loss of movement in both legs. Etiology and common lesion size: traumatic thoracolumbar spine fracture, dislocation, compressive port spine, commonest cause in India. Spinal tumor, extradural, intradural prolapse, intervertebral disc prolapse, intervertebral disc. Spinal tumor, extradural, intradural prolapsed intervertebral disc. Inflammatory, infective, transverse myelitis, epidural abscess, spinal TB. Inflammatory, infective, transverse myelitis. Inflammatory compressive port spine, commonest cause in India. Spinal tumor, extradural, intradural prolapsed intervertebral disc. Inflammatory, infective, transverse myelitis, epidural abscess, spinal TB. Inflammatory, infective, transverse myelitis, inflammatory, infective, transverse myelitis, inflammatory, infective, transverse myelitis, epidural abscess, spinal TB. 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 Vascular, anterior spinal artery thrombosis. Vascular, anterior spinal artery thrombosis. Anterior spinal artery thrombosis. Spinal atrioventricular malformation. Spinal anterior atrioventricular malformation. Demyelinated spinal demyelinating multiple sclerosis, MS multiple sclerosis, MS multiple sclerosis, NMO, Davies disease, NMO Davis disease, degenerative subacute combined degeneration, B12 deficiency, motor neuron disease, motor neuron disease, MND, motor neuron disease, MND, motor neuron disease, subacute combined degeneration, degenerative subacute combined degeneration, B12 deficiency, motor neuron disease, hereditary spastic paraplegia. Hereditary spastic paraplegia, common signs of lesion, thoracic cord, D4, D10, most common in pot spine, most common in thoracic, D4, D10, most common in pot spine, chorda equina, L1 below. Chorda equina, L1 below gives flaccid or flexic paraplegia with saddle anesthesia, gives flaccid reflexive paraplegia, gives flaccid reflexic paraplegia with saddle anesthesia, gives flaccid reflexic paraplegia with saddle anesthesia. Clinical features: spastic paraplegia, UMN, cord lesion above conus. Clinical features: spastic paraplegia, flaccid paraplegia, sensory loss, sphincter disturbance, back pain, spinal tenderness, deformity, gibbous in pot spine. Spastic paraplegia, UMN, cord lesion above conus, weakness with increased tone, exaggerated knee ankle jerks, extensor plantar conus. Clinical features: spastic paraplegia, flaccid paraplegia, flaccid, weakness with increased tone, but increased tone. Spastic causes UMN, flaccid causes LMN. Chorda equina, cord lesion above conus, exaggerated knee ankle jerks, extensor plantar conus. Flaccid paraplegia, LMN, chorda equina, anterior clonus, anterior horn, hypotonia, absent reflexes, wasting fasciculations if anterior horn cell, fasciculations if anterior horn cells, absent reflexes, hypotonia, absent reflexes, wasting fasciculations, hypotonia, absent reflexes, hypotonia, absent reflexes, wasting fasciculations if anterior horn cell, sensory loss with the sensory level in cord lesion, saddle anesthesia in chorda equina, sensory loss with the sensory level in cord lesions, saddle anesthesia in chorda equina, sensory loss with the sensory level in cord lesions, saddle anesthesia, sensory loss with the sensory level in cord lesions, saddle anesthesia in chorda equina, saddle anesthesia in chorda equina, sensory loss with the sensory level in cord lesions, saddle anesthesia in chorda equina, sensory level in cord lesions, saddle anesthesia in chorda equina, sphincter disturbance, urinary retention, incontinence, constipation, sphincter disturbance, urinary retention, incontinence, constipation, back pain, spinal tenderness, deformity. சுபனா ஏன் பக்கத்தில் வந்து பாடு, நானும் அப்போ பக்கத்தில் வந்துடுவேன். Sensory loss with the sensory level in cord lesions, saddle anesthesia in chorda equina, sphincter disturbance, urinary retention, incontinence, constipation, back pain, spinal tenderness, deformity, gibbous in spots, back pain, spinal tenderness, deformity, gibbous in pot spine, back pain, spinal tenderness, deformity, gibbous in pot spine. Investigation finding: use MRI spine holes when best level and nature of compression, cord signal changes, MRI spine holes when best level and nature of compression, cord signal changes. ஜிப்பு போட்டுரு, உள்ள பூச்சி அடைஞ்சிரும், ஜிப்பு போடு. பெஸ்ட் லெவல் அண்ட் நேச்சர் ஆஃப் கம்ப்ரெஷன், கார்டு சிக்னல், எம்ஆர்ஐ.
அதுக்குள்ள படுத்துட்டியா? 3 மணி எழுதி படிக்கிறேன்.
MRI spine holds spine best level and nature of compression, cord signal changes, X-ray spine vertebral collapse, Gibber's spots, fracture, X-ray spine vertebral collapse. MRI spine holds spine best level and nature of compression, cord signal changes, vertebral collapse, Gibber's spots, fracture, CSF steady, quick and steady test, block protein cell dissociation in cord compression, ESR, erythrocyte sedimentation, red montauk, CB, NAT, spinal TB workup. Serum B12 subacute combined degeneration investigations, VEP, SSEP, demyelination evidence in multiple sclerosis, VEP, MND, motor neuron disease, MND, motor neuron disease, MS, multiple sclerosis, VEP, SSEP, demyelination evidence in MS, VEP, SSEP, demyelination evidence in multiple sclerosis, VEP, SSEP, treatment, pod spines, ATT category, 1 6 to 12 months, HR is a T, pod spine, HR is a T, bed rest brace, surgical decompression, if neurological deficit, progress, pod spine, ATT category, 1 6 to 12 months, HR is a T, pod spine, ATT category, 1 6 to 12 months, HR is a T, best bed rest brace, surgical decompression if neurological deficit progresses, decompressive tumor, surgical decompression plus laminectomy, radiotherapy for malignant lesions, transverse myelitis, multiple sclerosis, 4-methylprednisolone, pulse therapy, plasma pheresis in resistant cases, supportive care, catheterization, bowel regimen, pressure sore prevention, DVT prophylaxis, physiotherapy for spasticity, baclofen, tizanidine, Siddha based management, kili podi, kili navarakili with vada pacifying leaves, rice for muscle strengthening, thailam, cotton chikadi thailam, dhanvandaram thailam for external application, abhyanga, internal vada kurandagai churanam, rasagandhi mega, amukara churanam, ashwagandha as nerve tonic, enema, vamana, Vasti equivalent Siddha procedures for Vada pacification per classical texts, mnemonic causes of paraplegia, picture, pot spine, mnemonic cause of paraplegia, picture, pot spine injury, cord tumor, pot spine injury, cord tumor, transverse myelitis, unusual B12, rare AVM, epidural abscess, pod spine injury, cord tumor, transverse myelitis, unusual B12, rare AVM, epidural abscess, pod spine injury, cord tumor, transverse myelitis, unusual B12, rare AVM, epidural abscess, pod spine injury, cord tumor, transverse myelitis, unusual SAD B12, rare AVM, epidural abscess. Example: paraplegia plus back pain plus Gibber's deformity in an Indian patient, pod spine until proven otherwise. Most common exam scenario: pod spine until proven otherwise. Most common exam scenario: flaccid plus saddle, anesthesia plus pink sphincter loss, early quad equina syndrome, quad spine, a surgical emergency. Quad equina syndrome is then quad equina syndrome is a surgical emergency. Quad equina syndrome is a surgical emergency. Quad spine until proven otherwise. Paraplegia plus back pain plus gibbous deformity in an Indian patient is equal to quad spine until proven otherwise. Flaccid saddle anesthesia. Sphincter loss early is equal to flaccid saddle anesthesia. Sphincter loss early is equal to Cauda-Equina syndrome, a surgical emergency. Poliomyelitis, definition and cause, acute viral infection caused by polio. Acute viral infection caused by poliovirus, picornavirus, RNA virus, 3 serotypes 1 to 3 that selectively destroys anterior horn cells of spinal cord and motor nuclei of brainstem. Asymmetric flaccid paralysis, spread fecal-oral route, sometimes respiratory droplets, incubation for 7 to 14 days. Definition and cause, acute viral infection caused by poliovirus, picornavirus, RNA virus, 3 serotypes 1 to 3 that selectively destroys anterior horn cells of spinal cord and motor nuclei of brainstem. Acute viral infection caused by poliovirus, poliomyelitis, acute viral infection caused by poliovirus, picornavirus, RNA virus, 3 serotypes 1 to 3 that selectively destroys poliomyelitis. Definition and cause, acute viral infection, acute definition and cause, acute viral infection caused by poliovirus, picornavirus, RNA virus, 3 serotypes that selectively destroys anterior horn cells of spinal cord and motor nuclei of brainstem. Asymmetric flaccid paralysis, spread fecal-oral route, sometimes respiratory droplets, incubation 7 to 14 days. Pathophysiology, virus enters via GI tract, multiplies in tonsils, pairs patches. Viremia, invades CNS via hematogenous retrograde axonal route, selectively destroys anterior horn cells. LNM of spinal cord, mainly lumbar, more than cervical and motor cranial nerve nuclei in brainstem. Bulbar polio result, element type flaccid asymmetric paralysis with no sensory loss, since only motor neurons destroyed. Classical manifestation, minor illness, abortive polio, fever, malaise, sore throat, GI upset, records completely more than 90% of infections. Non-paralytic aseptic meningitis, fever, neck stiffness, headache without paralysis. Paralytic polio less than or equal to less than 1% of infections. Pre-paralytic stage, fever, myalgia, hyperesthesia, paralytic stage, sudden onset, asymmetric flaccid paralysis, more in lower limbs, proximal more than distal, absent diminished DTRs, no sensory loss. Bulbar polio, cranial nerve nuclei involvement 9, 10, 11, dysphagia, nasal regurgitation, respiratory center involvement, respiratory failure, life threatening. Post polio syndrome, new weakness, fatigue, decades after recovery. Decades after post polio syndrome, new weakness, fatigue, decades after recovery from acute polio. Diagnosis, investigation, finding stool viral isolation, cold standard, 2 samples 24 hours apart within 14 days of onset. CFS steady, pleocytosis, lymphocytic, mildly rise protein, normal sugar serology, rising antibody titer, four-fold rise, EMG, NCS, denervation pattern, normal sensory conduction. Treatment, no specific antiviral treatment is supportive, bed rest, analgesics for pain, hot fomentation for muscle spasm, respiratory support, ventilator, iron lung and bulbar respiratory paralysis. Physiotherapy, once acute stage subsides, passive then active exercises to prevent contractures, orthopedic correction, tendon transfer, calipers for residual deformity prevention, OPV, oral live attenuated, and IPV injectable inactivated as per national immunization schedule. Pulse polio program in India. India declared polio free in 2014. Exam favorite fact. In 2014, India declared polio free in 2014. Exam favorite fact. Pneumonic polio myelitis features FVA and fever preceding paralysis. Asymmetric areflexia, areflexic, areflexia, no sensory loss. Example, key differentiator in exam polymyelitis LNM plus asymmetric plus no sensory loss, pure motor anterior horn cell disease. Unlike Guillain-Barre symmetric ascending may have sensory symptoms. Poliomyelitis LNM, lower motor lesions, asymmetric plus no sensory loss, asymmetric plus no sensory loss, pure motor anterior horn cell disease. Unlike Guillain-Barre may have sensory symptoms. Symmetric ascending motor neuron disease, MND. A group of progressive neurodegenerative disorders selectively affecting motor neurons, both upper and lower, with sparing of sensory systems, sphincters, and cognition. Classification: a group of progressive neurodegenerative disorders selectively affecting motor neurons, both upper and lower, with sparing of sensory systems, sphincters, and cognition. Classification type: neurons affected. Key feature: ALS, amyotrophic lateral sclerosis, progressive muscular atrophy, primary lateral sclerosis, PLS, progressive bulbar palsy, PBP. Neurons affected: UMN plus LMN plus UMN plus LMN, LMN only, UMN only. Bulbar LNM plus or minus UMN, LMN only, UMN only, bulbar LMN plus or minus LMN. Commonest type: mixed signs, amyotrophic lateral sclerosis. Commonest type: mixed signs, progressive muscular atrophy, PME. Pure wasting fasciculation. Primary lateral sclerosis. Pure spasticity, slow course, progressive bulbar palsy, progressive bulbar dysarthria, dysphagia, early etiology, mostly sporadic, 90%, 10% familial, genetic mutation, exact cause unknown. Glutamate excitotoxicity, oxidative stress, protein aggregation theories, clinical presentation, most sporadic, 90%, 10% familial, SOD1, C9 or F72 gene mutations. Etiology: exact cause unknown. Glutamate excitotoxicity, oxidative stress, protein aggregation theories, clinical presentation, UMN signs, spasticity, hyperreflexia, extensor plantar brusque jaw jerk, LMN signs, muscle wasting, fasciculations, especially tongue weakness, hyporeflexia, mixed UMN plus LMN signs in the same limb segment. A hallmark diagnostic clue: bulbar involvement, dysarthria, dysphagia, tongue wasting, fasciculation, no sensory loss, no sphincter involvement, no oculomotor involvement, cognition usually preserved. Exceptions: FTD-ALS overlap, progressive respiratory, muscle weakness, eventual cause of death, investigation purpose, EMG, widespread degeneration, fasciculations plus fasciculations in clinically unaffected muscles too. NCS: normal sensory conduction, normal conduction of sensory rules of neuropathy. MRI brain span exclude structure mimic cervical myelopathy tumor. EI escorial criteria diagnostic criteria combining human plus element science intelligence treatment. Riluzole glutamate antagonist modestly prolonged survival only disease modifying drug classically thought edaravone antioxidant newer option in some countries supportive NIV BIPAP for respiratory failure, PEG feeding for dysphagia, spasticity management, baclofen multidisciplinary palliative care, no cure management is largely symptomatic and support pneumonic MND, classic Q, mixed signs, no sensory, no sphincter, human plus element together in same segment with sensation plus bladder spared. Uh, Sensation and bladder spared motor neuron disease mixed signs no sensory no sphincter mixed signs no sensory no sphincter human plus element together in same segment with sensation bladder spared sensation bladder spared NMD MND motor neuron disease a pure motor neuron disease is a pure motor disease. Presence of sensory loss sphincter disturbance should make you reconsider the diagnosis. Think cervical myelopathy or another correlation. Instead, Parkinson's disease, Narcoadam, Panikambavadam, a progressive neurodegenerative disorder due to degeneration of dopaminergic neurons in the substantia nigra pars compacta, leading to dopamine deficiency in the nigro striatal pathway. Parkinson's disease, a progressive neurodegenerative disorder due to degeneration of dopaminergic neurons in the substantia nigra pars compacta, leading to dopamine deficiency in the nigrostriatal Nigrostriatal nigro striatal pathway pathological hallmark Lewy bodies alpha synuclein aggregates in substantia nigra siddha correlation Nadkoadam panikambavadam aggregated validosha causing tremor and rigidity due to disturbed pranan abanan vayu function pathophysiology loss of dopaminergic neurons, imbalance between dopamine inhibitory and acetylcholine excitatory in basal ganglia circuitry, disrupted direct indirect pathway of basal ganglia, bradykinesia, rigidity tumor, clinical features cardinal trap. Tremor, rigidity, akinesia, postural instability, resting 4 to 6 hertz, pill rolling, unilateral onset rigidity, cogwheel rigidity with tremor or lead pipe rigidity, akinesia, bradykinesia, slowness of movement, micrographia, hypomimia, mask-like face, reduced blinking, postural instability, stooped posture, fascinating gait, shuffling steps, retropulsion, other monotone soft pitch, hypophonia, drooling, autonomic dysfunction, constipation, orthostatic hypotension, REM sleep behavior disorder, depression, later cognitive decline, Cohen and Yar stage, Hohen, Hone and Yar staging, Hone and Yar staging, Hone and Yar staging. 3 4 5 unit involvement only no functional impairment bilateral involvement no posture instability bilateral disease mild moderate posture instability physically independent severe disability still able to walk stand unassisted wheelchair bound or bedridden unless assisted differentiated differential diagnosis atypical unitary environment only minimal no functional impairment bilateral no posture instability bilateral disease mild moderate posture instability physically independent severe disability still able to walk stand unassisted wheelchair bound or bedridden unless assisted differential diagnosis atypical Parkinsonism, Parkinson plus progressive supranuclear palsy, vertical gaze palsy, multiple system atrophy, autonomic failure, corticobasal degeneration, drug-induced Parkinsonism, antipsychotics, metoclopramide, usually asymmetric, no true resting tremor, essential tremor, action postural tremor, no rigidity, bradykinesia, often familiar, vascular Parkinsonism, lower body predominance, stepwise course, Wilson's disease, young patient, KF9, liver disease investigation, mainly clinical diagnosis, UK brain bank criteria, IBMRI, brain to exclude structural vascular causes, usually normal idiopathic PD, that scan dopamine transporter imaging shows reduced striatal uptake. Research tertiary centers trial of levodopa dramatic response supports diagnosis treatment mod drug class example notes dopamine precursor levodopa plus carbidopa most effective long term dyskinesia wearing of drug class example notes dopamine agonist pramipexole ropinirole used in younger patients to delay levodopa. MAOB inhibitors, salicylic, rasicylic, mild symptomatic neuroprotective climb. COMT inhibitors aim to carbon prolongs levodopa action, anticholinergics, trihexane, phenydial useful for tremor in younger patients, surgical deep brain stimulation. STNGPI advanced disease with motor fluctuations. Siddha aspect of treatment. Valivada dosha pacification is the mainstay. Thailam application Abhyanga Kottam Chukadi Thailam Shirabala Thailam internal Vada Kulandagai Churanam Amkra Churanam Ashwagandha రసగంధి మేగు విషమాషని వడగం నవరకిలి జవరకిలి Manchavarikili for muscle tone and rigidity relief. Yoga physiotherapy support advised alongside Siddha regimen. Mnemonic Parkinson's cardinal features tremor rigidity akinesia postural instability tremor rigidity akinesia postural instability example asymmetric onset resting pill rolling tremor dramatic response to levodopa classic idiopathic Parkinson's disease symmetric onset with early falls autonomic failure think Parkinson plus syndromes.